All right, the patient assessment process. So this is our investigative process by which we go through and find and discover all the things that are wrong with our patient and then ultimately arrive at an avenue of treatment as to how we're going to make our patient better. So this methodology that we use when we teach the initial classes sometimes, it's simplified, it's very compartmentalized, but I think it makes it a memorable way to go through this process. So when we talk about patient assessment, we always start with this compartment called the scene size up. And during the scene size up, right, these are all the things that I need to make sure that I have to do my job in my patient assessment process. So this is the stereotypical, right, and there's 6 things here, 1, 2, 3, 4, 5, 6, there's 6 things here, and this is the scene safety. This is the scene safe. Do I have my BSIs? How many patients am I dealing with? Is it a mechanism of injury or nature of illness? Do I need any additional resources? Remember, this isn't just ALS or manpower. We're talking about police, PEPCO, things like that. Any additional resources that I might require to run this call? Resources. And then one that gets thrown in here is C-spine precautions. And C-spine precautions are really important to utilize in this initial assessment before I've placed any hands on my patient, because as I move into my what's called primary assessment, I'm going to start putting hands on my patient and manipulating them, and I don't want to do that if I have any C-spine, potential C-spine injuries. So one of the things that's neat about this compartment is if we just remember that these are 6 things, right? These are the 6 things for me. The 6 things that I need to make sure that I have in order to mitigate this call that I'm going to go on. And this is the one, it starts at right at the dispatch. We get in the MDC, we look at the comments, and we start forming our opinions about how we're going to run this call. So that's the scene size up. The scene size up progresses into the primary assessment. And very conveniently, the primary assessment also has 6 points. And if this is the 6 for me, the 6 things that I need to run the call, these are the 6 things for the patient. So we'll say these are the 6 for them, right? The 6 for them, and that is the 6 things that they need to sustain life, to go on living. These are the 6 things we need to make sure are okay with the patient. So number 1, as I approach my patient, I form my general impression of the patient. And what I do here is I paint the picture to myself, general impression. So I paint a picture to myself of what my patient has going on. So in our stereotypical chest pain patient, I might say, all right, as I approach my patient in the living room of a single-family home, I find that my patient is sitting upright on the couch in his living room, and I see him clutching his chest, demonstrating that Levine sign. Maybe he's leaning a little bit forward, and he has a look of general distress on his face. Right? That's a really simple general impression. The other thing I do during my general impression is I just kind of get an overlay of the scene. And I check to see if there's any obvious life threats that need to be removed before I even start working on my patient. So that's my general impression. I've now formed my general impression, and now I make patient contact, and I want to determine my level of consciousness. Okay, my level of consciousness. Okay, so during level of consciousness, this is my AVPU. Right? Alert, verbal, painful, and unresponsive. Remember that when we get to U for unresponsive, it's unresponsive and not unconscious. There is a difference there. Okay? So I determine my level of consciousness, and then it's simply, I check my airway, breathing, and circulation requirements. Remember, if I have an unresponsive patient, I reverse this order, and it's CAB instead of ABC. But in my medical patient who's able to converse with me and speak with me, I simply go ABC. And when I check airway, okay, I need to know one of 2 things. Is it open or is it closed? If my airway is not patent, if it's not open, I go through these very basic measures to open my airway, either head tilt, chin lift, suctioning if that's what's required, placing the airway adjunct if that's what's needed, but I open my airway. So is it open or closed? When I assessed B for breathing, I want to know 3 things. I want to know what are the rate, the rhythm, and quality of those respirations. Right? So as they're breathing, keep in mind I'm not taking any vital signs during my primary assessment. I simply want to know, is my rate way too fast or way too slow? I'm not going to take the time to count this. This entire process of my primary assessment might take me 40 to 60 seconds. I'm not going to take the time to officially count my rate yet. I just want to know, does it appear to me, is it way too fast or way too slow? Rhythm, I want to know, is it regular or irregular? When they breathe, is it a nice rhythmic cycle, in and out, or is it sporadic? Is it irregular? And then quality. And what quality means here under B for breathing is from where I'm standing, even without a stethoscope, do I hear any adventitious lung sounds? Can I hear stridor as I approach my patient? As I approach my patient, do I hear any audible wheezing even without the stethoscope? Okay? Notice nowhere in here am I checking pulse ox, right? I don't even care about that yet. I just want to assess these values. When I move on to C for circulation, I also want to know, very conveniently, rate, rhythm, and quality of my pulse, right? So I find my patient's pulse. I determine the rate. I don't need the exact number. I want to determine, does it feel way too fast or way too slow? Is it nice and regular or is it irregular? And the quality, is it strong or is it weak? Okay. Additionally, in our C for circulation, I also evaluate my skin. And under skin, I want to know color, condition, and temperature. Right? This is my warm, pink, and dry, or my cool, pale, and diaphoretic. Right? So it's skin, color, condition, and temperature. And then our number 6 down here, right? Sometimes we say, I'm going to pause at the end and I'm going to assess POT. I want to determine my patient's priority, right? And I want to verbalize, I want to physically label them as a certain priority, 1, 2, or 3. O is oxygen. Do they need oxygen or not? As soon as I identify a problem with my breathing, that's the appropriate point to administer my oxygen. So priority oxygen, and then T is transport. So my transport considerations. And with my transport considerations, I want to know things like, when am I going to transport? How long am I going to stay on the scene? And where am I going to transport? Right? Am I going to go to a specialty referral center? Can I go to my closest hospital? And am I going to go lights and sirens, or can I go routine response? Okay? So POT, and at that point, I'm out of my primary assessment and I move into my secondary assessment.